Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. In the previous video, we saw how the aqueous humor is formed and all about the aqueous humor dynamics. So in this today's video, we will mainly discuss about the aqueous humor drainage system, that is involving the trabecular meshwork. So we will discuss the anatomy of the trabecular meshwork, how the aqueous humor is getting drained through this trabecular meshwork, how you visualize the trabecular meshwork, that is by means of using gonioscopy. So we will learn about gonioscopy, the various types of gonioscopes, how to use them, what are the advantages and disadvantages of each, okay, and how you see the angle structures when you see through the gonioscope. So without much delay, let's begin our video. So as you know, the aqueous humor is produced from the ciliary process here, okay, enters the posterior chamber, passes through the pupil and then comes to the anterior chamber, fills the anterior chamber and then goes to the angle of the anterior chamber. Okay, so here we have the important structure called as the trabecular meshwork. So this will pass through this trabecular meshwork and then there are so many ways through which the aqueous humor is getting drained into the venous system. So we will see the trabecular meshwork in detail now. So what is the literal meaning of the trabecular meshwork? It is nothing but a beam or the rod which will connect two structures giving support or helping in some function. So it is basically like a beam or rod like structure, okay. And this trabecular meshwork is nothing but a connective tissue core which is surrounded by the endothelium. So let's discuss about the trabecular meshwork. This whole colored thing which is shown in this picture is the trabecular meshwork. Hope you got the orientation. So just let me name the parts here. This is the scleral spur, okay, extending here all over 360 degree, some part of the ciliary body and then the insertion of the iris. And here we have the scleral sulcus, okay. As the trabecular meshwork gets opposed to the scleral sulcus, it converts it into a canal called as Schlemm's canal, okay. In the trabecular meshwork, we have three parts. It's like three sheets which are opposing over the scleral sulcus to form the Schlemm's canal. So the innermost one is the uveoscleral meshwork, the second is the corneoscleral and the third is juxtacanalicular. Just go by the name. So this is the uveal meshwork which is in opposition to the iris, the corneoscleral, okay, and then the juxtacanalicular which is around the Schlemm's canal. So let's see each one now. So this is the blue part is the uveal meshwork. So this blue colored one is the uveal meshwork. It is the innermost part. It is in direct contact with the aqueous humor. It is attached here to the ciliary body and the root of iris to the peripheral part of the cornea. Okay, as you can see, the pores are not so regularly arranged, okay, and they are quite big in size. It varies from 25 to 75 microns in size. Okay, so this is about the uveal meshwork. The second one, that is which is shown in the red color, is the corneoscleral part, which is attaching from the scleral spur and opposing and getting attached to the anterior wall of the scleral sulcus, okay. So this is the attachment of your corneoscleral meshwork. So this is in direct opposition to your Schlemm's canal. So it plays a major role in the drainage of the aqueous humor. And as you can see, the pore size is decreased compared to the uveal meshwork and it measures about 5 to 50 microns, okay. And the holes become smaller as it goes near to the canals. So here the inner holes are little smaller compared to the outer holes. These openings are nothing but the sieve-like things which help in the drainage of the aqueous humor. And one more important aspect of this corneoscleral meshwork is the longitudinal muscles of the ciliary body, which I have explained in my previous video, gets attached to the corneoscleral part of the trabecular meshwork, and the cholinergic innervation of the ciliary muscle has an effect in the opening of the trabecular meshwork. All your drugs which act, they mainly act on the corneoscleral part of the trabecular meshwork. And at the end of this corneoscleral part, it has an endothelial layer, okay. So what this corneoscleral and the uveal meshwork has, it has collagen type 1 and type 3 as well as elastin. Coming to the innermost part, that is the juxtacanalicular part, it is also called as cribriform layer or the endothelial meshwork. This again can be seen as having three layers. The outermost one is the endothelial layer which almost merges with the endothelium of the corneoscleral meshwork, okay. And the central part contains the connective tissue layer with a variable thickness and it is unfenestrated, okay. It doesn't have any opening here. and it contains only type 3 collagen. The innermost part of this trabecular meshwork is again endothelium, which is lining the Schlemm's canal. So this is about the trabecular meshwork anatomy. So just to recap, we have uveal meshwork, corneoscleral meshwork and juxtacanalicular meshwork. Just remember the pore size here. Okay, the pore size in the uveal meshwork is almost 25 to 75 microns, whereas in the corneoscleral it is 5 to 50 microns. As it goes near to the Schlemm's canal, the size of the pores decreases, and in the juxtacanalicular it is not fenestrated. Okay, hope now you understood the trabecular meshwork and got the orientation of the trabecular meshwork. So this is a 360 degree arrangement, means it is there all over the 360 degree angle structure. Okay, opposing to that we have the Schlemm's canal. So as the aqueous humor passes and goes through this trabecular meshwork, then finally it will end up in the Schlemm's canal. So aqueous humor will be pulled here almost. What happens after the aqueous humor enters into the Schlemm's canal? Finally it has to get drained through the venous system. So the veins which are involved are episcleral veins and the conjunctival vein. Okay, so in between we have intrascleral veins. In between these, between the Schlemm's canal and the episcleral vein, we have intrascleral veins. It is also called as collector channels. So there is peculiar arrangement of these collector channels like a direct system and indirect system. In direct system we have a large single vein which will drain into the episcleral veins, whereas in the indirect system we have numerous finer channel, okay, which form intrascleral plexus before draining into the episcleral vein. So ultimately it is draining into the episcleral vein, but some of the veins may go little more and then get drained through the conjunctival veins. Okay, this is about the drainage of the aqueous humor. So what I explained till now, that is the drainage of the aqueous humor from the anterior chamber, passing through the trabecular meshwork, entering the Schlemm's canal, then the intrascleral venous plexus, then the episcleral veins or the conjunctival veins, tells about the trabecular pathway of the drainage of the aqueous humor, also called as conventional pathway. So this is one more picture which shows the similar arrangement of the trabecular meshwork. As you can see, this is the uveal meshwork, corneoscleral meshwork and the juxtacanalicular meshwork, and then getting drained into the Schlemm's canal, and then through the venous system it gets drained to the episcleral or the conjunctival vessels. So in unconventional pathway we have uveoscleral as well as uveovortex pathway. Uveoscleral is nothing but the aqueous humor will enter the root of the iris. From there the interstitial space of the ciliary muscle goes to the suprachoroidal space, and through the scleral pores it reaches the episcleral tissue and the venous system. The second pathway, that is the uveovortex pathway, is not so significant. Okay, the amount of aqueous which is drained through this pathway is very less. So between the conventional and unconventional pathway, what is the percentage of drainage? The trabecular pathway or the conventional pathway contributes to 70 to 95% of the drainage of the aqueous, whereas the uveoscleral or unconventional pathway contributes to 5 to 30% of the drainage. Gonioscopy. What is gonioscopy? It is nothing but a procedure which is used to visualize the structures of the angle of anterior chamber. Okay, and this is done by using gonioscope. So what is the principle of gonioscopy? Whenever somebody tells about the principle of gonioscopy, the words which we frequently hear are like the total internal reflection, the critical angle. So I will explain what is that first. Okay, so whenever the light ray is passing from one medium to the other medium, there is some amount of refraction which is happening. Okay, so if the light ray is coming from higher refractive index media to the lower one, the light ray will get refracted and it moves away from the normal. So this is the normal. Okay, so the light ray moves away from the normal. So that depends upon the angle of incidence. If it goes like this, then the refraction would have been little more. So as the incident angle increases, it will go on bending away from the normal. So in this picture you can see the incident ray is such that the refracted ray is almost 90 degree to the normal. So this angle of incidence is called as the critical angle. Okay, so hope this is clear now. Critical angle is one with which the refracted ray is 90 degree to the normal. Okay, the angle of incidence is more than this critical angle, the refracted ray will come back to the same medium. This is called as the total internal reflection which is happening here. So when the angle of incidence is more than the critical angle, the refracted ray comes back to the same medium. It's not passing here. So the person who is seeing this structure will not be able to visualize this, because all the refracted rays are getting back into the same medium. So the exactly same thing happens in the eye at the angles. So this is shown in this picture. See, this is the ray which is coming from the angle structure. Since the angle of incidence is more than the critical angle, it is getting refracted back into the same medium, and the person will not be able to visualize this structure. Okay. So to overcome this, we use some lenses called as goniolens or the gonioprism. So when we use the goniolens, we are creating one more interface here. Okay. So previously it was cornea and air interface which was here, and now we have overcome this cornea and air interface and created one more interface, that is lens and the air interface. Here the angle is slightly less, so the light rays are getting refracted to the air medium, so the person will be able to visualize the angle structure. So the person is directly seeing the angle structure which is focusing. This is called as the direct type of gonioscope. We have one more type of lens called as gonioprism. So what happens in the gonioprisms, there is a mirror here. So the light rays which come here get reflected, and then the angle structures are visualized. Here we are seeing the opposite side of the angle structure. Suppose this mirror is kept inferiorly, then we are visualizing the superior part of the angle structure. Okay. So this is about the goniolenses. So this is the direct system of goniolens, and this is the indirect system of the goniolens. They are called direct and indirect because in direct we are focusing, that part of the angle structures we are seeing, whereas in indirect gonioscope we are seeing the opposite angle structure. What I explained till now is more than sufficient for undergraduates. Okay, just know the anatomy of the trabecular meshwork, parts of the trabecular meshwork and the pore size, and how they are visualized. They are visualized by using gonioscope. What are the types of gonioscope? Direct gonioscope and indirect gonioscope, and the principle behind the gonioscopy. And in direct and indirect, you just remember few examples. Like in direct gonioscope, the example is the Koeppe lens. In indirect, just remember Goldmann 3-mirror gonioscope. So this is more than enough for undergraduates. So what I will be explaining later is only for the postgraduates. So this is the direct gonioscope. This is called as Koeppe Gonolens. Okay. And for this procedure, we need gonioscope and a handheld biomicroscope and a light source. Okay. So what is the procedure of the direct gonioscope? After making the patient to lie down in the supine position and anesthetizing the cornea with topical anesthesia, the goniolens is placed over the cornea using balanced salt solution or the viscoelastic material. And then the examiner holds the biomicroscope in the hand. Okay, in one hand he will be holding the biomicroscope, and in the other hand the light source, and in some of the biomicroscope the light source comes along with, then the other hand will be free for the manipulations. Okay, and then he visualizes the angle structures. On which quadrant the examiner is concentrating, the same quadrant angle structures he is visualizing in the direct gonioscope. Okay, so what are the indications for this direct gonioscopy? It is mainly done in case of pediatric age group. So what are the advantages of direct gonioscopy? Here the height of the observer may be changed to look deeper into a narrow angle. It causes less distortion of the angle. We will be measuring the true depth of the anterior chamber. It can be used in sedated or anesthetized patient. It can be used to examine the angle structures in children, okay, under anesthesia. It is also useful when you want to examine the fundus through small pupil using direct ophthalmoscope. Okay, this can be used in surgical treatment of infantile glaucoma as well. So these are the advantages of direct gonioscope. So coming to the indirect gonioscopes, we have the prototype here, that is the Goldmann's 3-mirror gonioscope. Okay, so coming to the indirect gonioscope, we have the prototype called as the Goldmann 3-mirror gonioscope. We have 3 mirrors here. Okay, the tongue shaped mirror, square shaped mirror, as well as the trapezoid shape and the central lens as well. Okay, so just to remember, this is the rule of thumb. Okay, so here you can see the first one is the tongue shaped mirror, which is used to visualize the more peripheral part, that is the angle structure. The second one is the square shaped, okay, which is used to visualize the peripheral part of the retina. And the third one is the trapezoid shape, this one, which is used to examine the equator of the fundus. The center one is used to examine the posterior pole of the fundus. Okay, So these three mirrors are inclined at an angle. You should know the degree of angle of inclination. So I have shown in the picture the degree of angulation of each mirror and the power of the central lens which is used. So these are the frequently asked questions for postgraduates in Viva. Okay, so the angle of inclination of these three mirrors as well as the power of the central convex lens which is used. So this is about Goldmann 3 mirror gonioscope. Next one is Goldmann single mirror, where we have only single mirror here and it is inclined at an angle of 62 degrees. Okay, and we have to rotate this single mirror almost 3 times to cover all the quadrants and to visualize all the angle structures. Next is Goldmann's 2 mirror, where we have 2 mirrors here, okay, which are again inclined at 62 degree angles. But the advantage is if we just move it once like this, we will be examining all the 4 quadrants of the angle structures. Next we have ZEISS 4 mirror goniolens. Here we have 4 mirrors, okay, which are inclined at an angle of 64 degrees. It has an Unger fork here, okay. It has an Unger fork handle to hold the goniolens. This is the ZEISS 4 mirror. In the POSNER's goniolens, we have an inbuilt handle. Otherwise, it is similar to the ZEISS 4 mirror. Means it also has 4 mirrors to visualize the angles. The SUSSMAN's goniolens, it also has the 4 lenses, but it doesn't come with Unger fork handle also and the inbuilt handle also. The advantages of this ZEISS 4 mirror, POSNER's and the SUSSMAN goniolens is at once you will be able to visualize all the angle structures. You need not move the goniolenses. Okay. So what is the differences between all these lenses? The difference is mainly with the posterior curvature of the goniolenses. Okay. The posterior curvature of these lenses is steep. Okay. The radius of curvature is almost 7.38 in case of Goldmann lenses. So this is steep compared to your cornea. Okay. So there is a potential space between, and this has to be filled with the balanced salt solution or the viscoelastic substance to visualize the angles. Whereas this ZEISS 4 mirror or POSNER's goniolens or the SUSSMAN lenses, the curvature is very less. The posterior curvature is almost equal to the anterior curvature of the cornea. So here you don't need any coupling fluid. Okay. And one more difference between these Goldmann lenses and the ZEISS 4 mirror is the area of contact of this posterior border over the cornea. Here it is almost covering the cornea or it is almost at the limbus. Okay. ZEISS 4 mirror, the area of contact is less. Okay. It is just touching some part of the cornea. So that is helpful when you are making indentation gonioscopy. Coming to the procedure of indirect gonioscopy. So now you know the various types of indirect gonioscopes. So first I will be explaining about Goldmann lens. In Goldmann lens, what we do, first you anesthetize the patient's cornea with the topical anesthesia. Make the patient to sit in the slit lamp. Okay. As I told, there is a gap between the posterior surface of the lens and the cornea. So you have to fill this posterior part of the lens with a balanced salt solution or the viscoelastic material, and then gently retract the lower eyelid and place the goniolens over the cornea. Make sure that air doesn't come in between. Now you will be able to visualize the angle. Okay. Remember, you are seeing the opposite part of the trabecular meshwork. Suppose the mirror is at superior quadrant, means you are visualizing the inferior half of the anterior chamber. After analyzing the angle structures, rotate the goniolens to visualize the next part of the trabecular meshwork. So this is what you do in Goldmann's types of goniolenses. Whereas in case of ZEISS mirror, just anesthetize the cornea. There is no need of coupling fluid. Then you just place the lens and examine the trabecular meshwork. Suppose you are finding it difficult to visualize some quadrants, especially the nasal quadrant is little difficult to visualize, then you can do some manipulations like ask patient to look in the direction of the mirror. Okay. Then the angle structures will be little more easily seen. Coming to one more type, that is called as indentation gonioscopy. This is done using either ZEISS 4 mirror or POSNER's goniolens or the SUSSMAN lens. To carry out this procedure, the contact area of the goniolens should be less compared to the total diameter of the cornea. So this can't be done using your Goldmann lenses. So what is the procedure? Just give gentle pressure over the cornea, that is indent the cornea to some extent. Then there is displacement of the aqueous towards the angles. So if it is just an oppositional angle closure, then the angles will open up and you can visualize the angle structures. but if it is firm synovial closure, then you will not be able to visualize the angle structure. So the indentation gonioscopy can differentiate your oppositional angle closure from the synovial angle closure, and this can be done only with these ZEISS 4 mirror, POSNERs or the SUSSMAN, but not with the Goldmann types of goniolenses. So this is about manipulating gonioscopy and the indentation gonioscopy, also called as compressive gonioscopy. What are the advantages of indirect gonioscope? Here, since we are using slit lamp, the optics of the slit lamps will give a good visualization of the angle structures. It is faster than your direct type. Compressive gonioscopy and the indentation gonioscopy can be done, which will give more information about the angle structure. So these are the advantages of indirect gonioscope. So what you see when you visualize the angle. So this is the thing what you observe when you see through the goniolens. So from anterior to posterior we have Schwalbe's line, okay, trabecular meshwork, scleral spur and the ciliary body band. Let me explain how each structure will look. So Schwalbe's line is the anterior most structure, okay. This is the Schwalbe's line. It appears as irregular opaque line. Anatomically it demarcates the peripheral termination of Descemet's membrane and the anterior limit of the trabeculum. Structure is the trabecular meshwork, which is pigmented, okay, and seen anterior to this white line called as the scleral spur. In the trabecular meshwork we have two parts again. The anterior little non-pigmented part, which is in opposition or in close line with the Schwalbe's line, okay, and this is not so important in the drainage of the trabecular meshwork. Whereas the posterior pigmented part, which is just opposite to the scleral spur, is very important in the drainage of the aqueous humor because it lines directly over the Schlemm's canal, okay. And the third one is the scleral spur, which is seen as a white band here, okay. This is the scleral spur, which is the anteriormost projection of the sclera. And the fourth one is the ciliary body band, which lies posterior to the scleral spur, okay. It is pink to dull brown to slate grey in color, and the width of the scleral body band depends upon the position of the iris insertion, and it tends to be narrow in hypermetropic eyes whereas wider in myopic eyes, okay. Then comes the iris processes here. These ciliary processes are nothing but the small extensions of the anterior surface of the iris, which insert at the level of scleral spur and also to the ciliary body to variable extent. It should not be confused with the peripheral anterior synechiae, which are usually broad. Then one more structure which may be visualized is the blood vessels, okay. So these blood vessels can be physiological or pathological. The physiological ones, they are usually radial in pattern at the base of the angle recess. Pathological blood vessels usually run randomly in various directions. So these are the angle structures which you visualize. So Schwalbe's line, the trabecular meshwork, scleral spur and the ciliary body band. For the beginner, it is always easy when you examine the myopic patients to visualize the angle structures, where you will appreciate ciliary body band, scleral spur and trabecular meshwork very well. As a beginner, just remember, if you see a white line with two pigmented layers on either side, it means that angle is open. So this is one more picture where you can see the angle structures, okay. So the white line which is seen here is the scleral spur. Anterior to it is the trabecular meshwork and the posterior to it is the ciliary body band. So how you grade the angle structures? We have two types of system to grade the angle structures, the Schaffer system and the Spaeth system. But the Schaffer system is most widely used. So in Schaffer system, it records the angle in degrees between two imaginary lines, okay, which are tangential to the inner surface of trabeculum and the anterior surface of the iris. Schaffer system, the angles are graded from 0 to 4. You can't actually measure the angle, but if you can see the structures up to ciliary body band, then the angle is said to be of grade 4, okay. It is usually seen in myopic patients and the aphakia patients, where all the angle structures are seen and it is wide angle. In grade 3, the angle measured is 25 to 35 degree. Here you can identify up to scleral spur, that is the white band, okay. In grade 2, it is up to 20 degree. It is moderately narrow angle where you can see only the trabecular meshwork. Whereas in grade 1 it is only 10 degree of angles which is seen, means you can see only up to the Schwalbe's line or the top part of the trabecular meshwork. Then we have one more called as slit angle, in which there is no obvious iridocorneal contact, but there is no angle structure which can be seen. In grade 0, the angle is closed due to iridocorneal contact and is recognized by inability to identify the angle structures. Okay, so how you sterilize these goniolenses? After using on each patient, just keep the goniolens under flowing tap water and wipe it with lint-free cotton material. Okay, or you can use 70% isopropyl alcohol to just wipe the posterior surface of the goniolens. So how you document this angle structures in your case sheet? This is done by using Becker's goniogram. We have mainly 3 circles here. Okay, the inner one is the scleral spur, the inner one is the scleral spur, the middle one is the trabecular meshwork. Here it is shown in 2 circles, and the outer one is the Schwalbe's line. Depending upon which structure is seen, just mark that area. Okay, and before doing that, it is just divided into 4 quadrants, and each quadrant you visualize and mark the structures what is seen, and also the abnormal things like blood or the peripheral anterior synechiae, membrane, everything you can show in this Becker's goniogram. But one more method which is clinically used is just write this cross and mention which structure is seen in which quadrant. Suppose in this quadrant you can appreciate up to the trabecular meshwork, just write trabecular meshwork. You can see up to the scleral spur, then you just write scleral spur. Here again trabecular meshwork is seen, just write TM. Okay, so like this you can depict in the case sheet. So what are the abnormalities you can see? I am just giving the examples of the abnormalities which is seen here, and when I explain each type of glaucoma, I will be specifically explaining about the abnormalities which is seen in the gonioscope. So the peripheral anterior synechiae can be seen in primary angle closure glaucomas, anterior uveitis, iridocorneoendothelial syndrome. Neovascularization in case of glaucoma, neovascular glaucoma, fuchs heterochromic cyclitis, chronic anterior uveitis, hyperpigmentation of the trabecular meshwork seen in pigment dispersion syndrome, pseudophakic pigment dispersion syndrome, pseudoexfoliation, blunt trauma, nevus of aorta. And what can be the findings in case of trauma? The angle recession, trabecular dialysis, cyclodialysis, foreign bodies can be seen, and blood in the Schlemm's canal can be seen in carotid cavernous fistula, Sturge-Weber syndrome. Okay, superior vena cava obstruction, and it can even be physiological variant when you apply more pressure with the gonioscope. So hope this video was useful on the gonioscopy. If you like my videos, please do subscribe to my channel. Press the bell icon for the further notification. Please do like and share my videos. Thank you so much.